All right, so let's jump in. I'm here with Benjamin Katz, who is a doctoral candidate at Hebrew University in Jerusalem, and who has been doing a lot of research studies lately, looking at questions of mental health in the context of COVID-19. There's been a lot of discussion around, what are the consequences of this pandemic for mental health, and questions of social distancing, questions of social isolation, issues of, different experiences for different people, different countries, different backgrounds, and so on. And Ben just recently completed a study that he's lead author on, and he's involved in a lot of other research, taking a look at some of these questions. So Ben, thank you for being willing to chat and share some of your experiences and your expertise. Would you be willing to just give us your impression of the research that's been done in this area and what we're learning, and the work that you've been doing to try to tackle these questions?
Sure. So I guess let's start with kind of the problem that we're dealing with before us. I've seen it referred to otherwise that any kind of research phenomenon of interest is kind of like trying to light up a mountain in the dark. Where every study is going to be a different flashlight and you're trying to work it out. Mm-hmm. What we're dealing with now, it was a full mountain range that kind of sprung up overnight. One of the mountains is about the economics of it all. One is about the physical health of it all. And I'm here with the mental health part of it. So what we've been seeing at the beginning of the pandemic, a lot has been coming out from, let's say, March through August, a lot of theoretical work. So a lot of people who have worked on these kinds of things before, you yourself, have been on some of those theoretical papers, kind of, to go with the metaphor, people who have seen many mountains before, have an expertise in the general shape of the mountains, and saying, okay, this is what we may be facing here. This is a theoretical map. These are the kinds of things we could, loneliness can trigger depression. Isolation can trigger suicidality. And not speaking about it in terms of actual metrics that we've seen, but speaking about it kind of more in the abstract. Where I've been involved is already the people who are going up to the mountain with our little flashlight and kind of setting up our flashlight over our little 4x4 feet around it and saying, okay, here's a little corner of the mountain that I'm able to light up. And that's already studies which are based on empirical data. It works best when there's more cooperation among the research community. I'll just say, as a big picture view, it's been pretty amazing watching all of that happen. You yourself are leading one of the consortia, but you're seeing it on Twitter and Google Docs and things like that. You students, if you're interested, ask Professor Hallian about it. The amount of cooperation going on behind the scenes to make sure that each of our flashlights are posted in different places and we're all facing different questions, which are also working with each other, has been amazing. So that's kind of what's been going on big picture right now. It's October 2020, and we're starting to see some research coming out from the beginning of the pandemic. What happened in March and April when we look back on it, when it first hit, how have people been reacting? And that's what my paper has been about. So again, my tiny flashlight on this very big mountain concerns a group of about 220 participants from North America and the UK. It was a separate study that we did in October 2018 and April of 2019. We checked different metrics of depression, anxiety, emotion regulation, certain personality traits of theirs. And we did it over 2 different time points. And then when the pandemic started hitting in April, we went back to them exactly 1 year later.
That's so cool.
Yeah, I mean, it is, extremely unfortunate how perfect our timing was, but by pure coincidence, the distance from the second time point to the COVID time point was exactly 1 year. I think it was, April 15th to 20th, both years. It happened to be that those 5 days in 2020 were the highest fatality rate in North America and the second highest in the UK.
Oh, wow.
Yeah, so it was during a time, already now in October, we kind of got used to it, but it was a time of extreme uncertainty, extreme stress, And to be honest, we didn't even know how to treat it. So there was a very palatable fear at the time. So we were interested in seeing not just how stressed out were people, but also how much did that actually translate into clinical psychiatric symptoms. And what was especially valuable about that is that a lot of research that deals with, disasters in general, hurricanes, economic downturns, terrorist attacks, most of them will either be cross-sectional, meaning it'll take place in that moment, or it'll be longitudinal, spaced out over time, but only starting at that moment. So we know very, very little about the people going into it before that kind of trauma occurred. And that was something that we were able to bring to the table.
That's really exciting. And so can you share a little bit about maybe just briefly kind of what the study approach was and then what you ended up finding?
We kind of looked at two different theories. Theory number one said that coronavirus-related stress was going to make people more depressed or anxious. Theory number two was that people who already had a vulnerability for depression or anxiety would themselves be more stressed. Okay, so kind of the question of what's leading to what here. And we tested each of those models against each other. Okay, we use something called structural equational modeling. You could look it up. If you're interested, you could look in the paper. We explained a little bit. But the main thing which is important here is that we weren't just looking at their depression and anxiety and stress at the point of the study. We were comparing it to where their depression and anxiety was 1 year prior. So we were able to see not only how depressed or anxious were you, but how much did that change compared to where you were. And when we compared the two models against each other, first of all, we expected depression and anxiety to go up. They did not on the level of the group. We were very surprised. For depression, we ran tests. It was actually equivalent between the first two time points before the pandemic to during the pandemic, again, at the height of isolation and fear and all of that. Anxiety actually went down to a very trivial degree. We didn't think it was clinically significant, but it was quite surprising. And part of what we found was that when we compared the two different explanatory models against each other, stress leading to depression and anxiety was a terrible fit for our data. What ended up fitting our data was that people who came in with vulnerabilities to depression and anxiety during the pandemic reported feeling more lonely and more stressed. Mm-hmm. So as clinicians, it was kind of asking, what should we be focusing on here, right? Should we be especially attentive to people who are getting isolated and people who are stressed? Yes, but you should also pay some very strong attention to people who you know have in themselves a history of depression and anxiety. Because people who have those kinds of histories and maybe even have those kinds of vulnerabilities, even if they're not telling you how tough it is right now, the numbers are saying they are at higher risk for feeling especially lonely during isolation, especially anxious and stressed out during this time of uncertainty. And that's a place where it's important for researchers and clinicians to kind of know who we're dealing with, not just right now, but also where they were coming from, because those vulnerabilities really matter.
Yeah, and you're getting something really important there, which is this difference. There's some discussion between, these approaches of nomothetic versus idiographic, what's happening at the group level versus what's happening for people or groups of individuals. And you're touching on something really important, which is that you're finding, it sounds like overall, at least in those early stages, there wasn't a measurable sudden increase in depression, anxiety, psychopathology across the board. And yet at the same time, there were some folks who did end up really struggling. And then presumably on the flip side, some folks who were likely doing perhaps even better than expected.
I think that's such an important takeaway because empirically supported interventions are important because we can have two different ideas that make a lot of sense and that are even theoretically supported. A lot of these papers we're talking about, the COVID-19 pandemic kind of being associated with a new pandemic of depression and anxiety. And that's one form of kind of population level intervention that we should think about. Mm-hmm. But at least our finding, and again, I don't want to overemphasize anything, our little flashlight in our very big mountain which we're shouting to other people, you know, if you're also finding this, we need to talk about it more, is that what we really need to focus a lot of our research and clinical energy on is really going to be finding out who is the most vulnerable and who needs the most targeted intervention. Because again, on a population level, we tend to be resilient. You know, we're resilient to hurricanes, we're resilient to earthquakes, we're resilient to terror attacks, to a lot of very difficult things. But there are people who get hit really hard. And before we even start on helping them, we need to find them. And I think that's one of the really big takeaways that you know, I want people to take from our paper.